Fantastic. So welcome everybody. So I'm Daniel. There's a bunch of new folks on the call here. So welcome to the Unify call for today. And we have just a few updates. We'll do some quick introductions for folks who are new to the call, just hear where you're from. But just I wanted to provide a couple of updates. Fresh from Austin, we have Brian Hansvicker, who'll give us a quick update on what's going on with IHE and preparation for HIMSS down there, and then a quick update on where we're at on the Learning Lab, and then we'll spend most of the time with Beya Thayer and colleagues and friends talking about Yavapai County and the amazing stuff that's going on there. We oftentimes don't spend enough time with our justice partners and people who are working in the jails and prisons and parole and probation and all that kind of stuff. So you may remember from a while ago when Beya spoke with another colleague, it was hinting at some of the great work that was going on there. So when she does start up, one of the things we talked about in preparation was to think about using this group here as a Q&A board as they're presenting. There's a request for how do you solve some of these technical problems as well. So I promised you all would step forward and offer your suggestions. So let me just see while we do this. So new people on the call, if you would just come off camera and just say hello and where you're from, that'd be great. So why don't I'll just name a couple of folks here who I don't remember. Gabby Elzinga.
Hey everyone, my name is Gabby Elzinga. I'm a senior project manager with the Office of eHealth Innovation here in Colorado.
Welcome, welcome. So I'm just going to pick on people. I'm going to ask Kelly and then Sandy and Don Jacobson to say, and then Shannon.
Hi everyone, Kelly McGann from Contexture, formerly in Arizona. It was known as Health Current. And I apologize for the background. I am in the airport on my way also to Texas.
Great, welcome, thanks. Sandy.
Hi, I'm Sandy Hoppo. I'm a community corrections manager for the Community Corrections Division of the Arizona Department of Corrections, Rehabilitation and Reentry. I'm a reentry manager.
That's one of the things I've noticed about you folks. You guys, very long titles. How
I
do you
know.
get them on the cards?
Very small print.
Don Jacobson.
I'm Don Jacobson with the Arizona Supreme Court. I'm a senior special project consultant working in the mental health arena.
Welcome, thank you. Nick.
Hi, Nick Ferrari with Find Help. I'm currently working, we're the largest social care network in the nation and currently working with departments of corrections across the nation to help decrease recidivism, as well as increase reentry services, supporting probation and parole teams, reentry case managers, and education units. And thanks for having me.
Oh, this is going to be a great call. I think I see one other name, Shannon Giovanni.
Hi, my name is Shannon Johanni. I'm the research director at the Academy for Justice at Arizona State University, Sandra Day O'Connor College of Law. My title is very short, but my work is very long. So,
okay, welcome. I think I got everybody. Anybody I didn't call on? I don't know who 480 is though. So, whoever 480.
Daniel, it's Mary Sarah.
Okay, darling, welcome. I should have known that by now. Arizona number at that. I'll add that in. Okay.
I'm at the PMIC, I'm an epidemiologist.
Okay, great. And then Beya Thayer, who is in my upper left-hand quadrant. So welcome, Beya, to the call today, and we'll get to it in just a second. So it'll be interesting. So Brian, from you want to give us a few words on what's happening down there? Oh, I think you're still on mute.
Thank you for the reminder. I think I have a T-shirt somewhere that says you're on mute. You know, this is part of the modern human experience. I'm at an IHE Connect-a-thon in Austin, Texas. IHE is an international organization associated with trying to expand support for interoperability and standards for healthcare information exchange. And they run very well-structured connect-a-thons and project-a-thons. Think of project-a-thons as being ad hoc connect-a-thons for individual standards projects that attempt to identify whether or not there are issues associated with interoperability between various companies' products. And so here in Austin, Texas, we've got a testing floor, a connect-a-thon floor with between 50 and 60 people in it by my quick count when we were given a little tour of the floor. Everything from electronic health record systems, infrastructure, interoperability infrastructure providers, to companies building medical devices, from continuous glucose monitors all the way through MRIs, though I didn't see any MRIs on the connect-a-thon floor yesterday. But I saw some rather interesting looking devices in the devices area. So they're doing serious stuff and very important stuff for interoperability testing for the healthcare community. I was also here yesterday for what was called the IHE Experience Day. Basically, hey, what are the new things that are going on in interoperability for the healthcare world? And I was a speaker speaking on, I think it ultimately ended up, I think it was originally proposed as e-consent and equitable interoperability. I think I managed to screw up the title when I made the slides and called it e-consent for healthcare and across healthcare and social care. But it was very well received. Everyone agrees that yes, this is an important issue. How do we extend the concept, the health IT concept of electronic consent from healthcare into the social care world and deal with some of the unique characteristics of dealing with privacy, consent, and authorization to share information in the social care world. And the fact that the social care world is different than the healthcare world. So that makes it a little more challenging to try to address the concerns of e-consent. It was extremely well received, including by some of the leading luminaries, if you will, from the healthcare consent world, the healthcare standards consent world. So we've made a bunch of new friends, and we now have folks with a better understanding of the challenges ahead of us in electronic consent for social care. And I look forward to some enthusiastic participation in next month's e-consent workshop at HIMSS. And I turn it back over to you to talk about that, Daniel.
Yeah, and actually one thing I was just going to follow up on is the showcase, because part of what we're going to be doing after the learning lab is Tuesday through whatever, Wednesday, Thursday, Friday, whatever it might be, or at least for a couple of days, we'll be in with IHE in the learning lab or in their booth, talking about some of the stuff that you guys have been working on and stuff Unify has been working on, right?
Exactly, and we do have the beginnings of I'm restructuring it as a Unify proof of concept demo that we'll be able to show a video of in the IHE Connect-a-thon space. And I bounced this off of Amit and Evan and others from from HIMSS and IHE to make sure that the idea of doing a video versus a live presentation was an okay idea. And Evan in particular laughed and said, yes, that's a very good idea. When you do demos and connect-a-thons and something doesn't work, either because the network is down right now or somebody's system isn't been configured properly, et cetera, et cetera, et cetera, that's okay. That's part of doing a connect-a-thon, is to identify challenges and try to fix them. We call it failing forward. However, in a demo space like HIMSS, you don't want to have to figure out in real time, when you've got a narrow 1 hour slot to present in, whether or not there's a technical glitch that's creating a problem. So they were supportive of the idea of us doing this as a demo, proof of concept demo for Unify in the week or two before HIMSS, and then presenting a video of that during HIMSS. And Daniel, I hope that's okay by you.
Fantastic. No, that's exactly what we want to be able to do, because we have a great opportunity to extend this out into, for the whole week while we're at HIMSS, and then into 23, 24 going forward.
Without necessarily having every single one of the technical people involved in it standing there by your side every time you want to show it. But for those of us that have booths at HIMSS, there's nothing stopping us from supporting live demonstrations of it in our booth. And then, if something goes amiss in the process, it's not a big deal. We just solve the problem and say, come back in 5 minutes. Not something we can really do when we've got a 1 hour presentation slot.
Yeah, that's fantastic. Very exciting. That's great. And you're coming back what, tomorrow?
I'm coming back tomorrow.
I
have to get back because I have a new grandson, and though I don't have much to do with it, my lady love Janine desperately wants me home to take care of the critters so that she can go take care of the grandson.
All right. Well, I hope the weather gods are with you tomorrow as we move forward.
I haven't been paying attention. I hope there's nothing I have to look forward to.
I don't think it's hurricane season anymore.
I'll be sure to let you know when it is.
All right, you get the easterly view of that, right, Jim?
Yep, I can give you the up close and personal.
Don't mess with Texas, right?
That's right, or Louisiana, Alabama, Florida, or Mississippi.
Great to hear. Any questions for Brian before we jump forward? Any thoughts? All right. Well, if they come to you, feel free to bring them up. So just a couple of things that are happening now, just to update folks, because it'll drive kind of what we're doing in the next couple of months here. So as I reported last time we met here, we are rapidly hurtling towards a learning lab at HIMSS on April 17th. And it's kind of all come together, which is great. And we will be bringing people together for about half a day. And we'll be talking about issues related to consent. And invitations went out this week to a group. We're only going to have 50 people there in the room with our HIMSS government affairs partners. So a first salvo of invitations went out, and we'll be over the next week or two sort of trying to solidify that group. And then what I want to do is I want to bring folks together probably in 3 weeks, not either in 2 weeks or 3 weeks, kind of like a regular call we're having for Unify, but to focus on the agenda for the HIMSS Learning Lab. Because a lot of people will be involved with it, and the whole intent of it is just to sort of spin up a bigger national audience for this consent work. And many people on this call and many people who've joined in the past are really interested in that. So that'll be pretty exciting. So you'll be invited into we'll reviewing some of the questions and some of the topics, and some people will be there. And we're trying to figure out if we can live stream it. from HIMSS as well. So folks who can't be there can join us for some of the sessions. And we hope to generate some valuable policy related ideas that maybe could be implemented rather quickly. So that's what's happening. We're kind of super focused on that right now. As I said, reaching out to folks and trying to organize what that's going to look like, and then bring that back to this community after April 17th. One of the things that we're talking about with HIMSS and they want to do an ongoing learning series on this and related things. So I suspect over the next 6, 9, 12 months, we'll have the opportunity to really build out the work we've been doing here with a set of regular conversations with ourselves and maybe with others who are interested in the work that and whatever spins out from the workshop at HIMSS itself. So it's awkward to just have a kind of an invitation only kind of approach, but it's the only way we can sort of manage this one. But if you have a real interest in attending and you think you can contribute to that conversation, by all means, send me an email or put a note in the chat. And as we kind of work through the registration, we'll open it up to folks who express a lot of interest. So feel free to do that. Then the last thing, well, let me just pause I'll just say one more thing. So Chris Kingsley, who's at Annie E. Casey Foundation, some of you may know him from the data quality campaign from years ago. I was talking to him today about what we're doing on consent and how it relates to child welfare and all those kinds of issues. But he mentioned that they actually have an open position, which is kind of cool, for a senior associate for data tools and measurement. If those of you who know Annie E, they do some really great research and really good information for the field. So if you're interested, they're taking resumes. And I told them I'd be promoting that. So there you go. So before we turn to the presentation, are there any questions, thoughts? Yeah, you guys do hear me, right? Okay. So let me move on here. Just a couple of slides. So 2 weeks ago, we had a great presentation from Meld and from May June. And that recording is now up on the NIC site. I'll put the link for you, but it was great. And for those of you who missed it, I just want to shout out, give kudos to them, because it was an excellent presentation and just really focused on the future and the work with Meld and May June and assessments and all that kind of stuff, and kind of what Brian was talking about before and some of the demos kind of all ties together. So I encourage you, if you haven't seen it, it's really worth the time to go listen to it and watch it. It's just chock full of great stuff. And with that, let me turn it over to Beya. And so Beya, we got to know each other last year through Sean Gunderson and some work we did in Arizona. And I was so impressed with what you guys are doing to try to reduce youth involvement and diversion programs. And then I think, as I recall, we had a conversation with the folks in DC. So there was some interest there as well from Christy Love, who's running that department, that agency. It was kind of an interesting question around how do you address some of these real challenges, which are in the news every day now. And I was so impressed with what you guys were doing there. So I'm glad that you're here today and will be, kind of sharing with us the story of what's going on there. And with that, let me turn it over to you. Do you want to, I don't know if we answered, do you want me to run the slides or you want to run your own? You can just.
You can run them. It's okay. Because then I'd have to find them on my computer, correct?
Okay. Right.
Yeah. At this point, it's easier. All right. Well, thank you for having me here. Everyone, I am Beya Thayer out in Yavapai County, Arizona. Yavapai is a county, one of our 15 counties, and it's geographically the size of New Jersey, and it has about 250,000 people in it. and there's a mountain range that goes through the middle. And so it's definitely falls under the world of quite rural out here. And but it's pretty great to work with. It's pretty innovative. There's a lot of amazing partners and stakeholders here in Yavapai. I'm actually going to talk to you about this big project that we're hopefully going to get started really soon with our cross-system recidivism tracking database. And one of my friends, Don Jacobson, who is here on the call as well from our administrative office at the courts at the Supreme Court level, he had reached out to the sheriff and I a couple years ago and said, hey, you know, you got all this jail coordination going on and a lot of great stuff with your database and how different folks can access the database. And our whole jail reentry coordination is kind of based around like what this database can do. Can we make the data, can we just replicate it and make it available for the other 14 counties so that they can also jail reentry coordination, and we can pretty much collect the same kind of information and have apples to apples and have the Yavapai model kind of spread out throughout the state, which of course we would love for the Yavapai model to spread everywhere as far and fast as we can. But the database itself was kind of a pilot project, and it's what I consider to be the Taj Mahal that was built on stilts, and it's about to collapse. And so through Don and through his connections, and the next thing you know, we got hooked up with this entity called the Nerdery, and they were a tech company that's mission was to find these old antiquated systems that people are using and bring them up to the 21st century. So we got to do this crazy dive into our program and all the ins and the outs and the outputs and who's touching what and where all of the bad spots are. And they created this fabulous blueprint model that would be able to put us on a cloud base, and whether they're going to do it or some other smart tech company that loves this stuff would like to do it. Like, we have the blueprints for it, and we go to the state legislature quite often to help fund our jail reentry coordination program. And so as we were doing that, and I'll explain a little bit more of that later about how the state comes involved, we now have legislation going through the legislature that would provide $3 million that would go through our Arizona Criminal Justice Commission in order to redo our database to the 21st century so that the Taj Mahal does not collapse down on its stilts. And as all of this discussions and stuff are happening, and I got to meet Sean and start talking about the interoperability and how all these different entities come into play, it's kind of my world is getting shaken up over what some of these possibilities are. I am a social worker. If the world was filled with a bunch of Beyas, we would not be sitting here on Zoom looking at a computer. We'd be writing notes. I don't know how we'd be communicating, but I am not a tech person. And so I'm in awe about what the possibilities are when it comes to our mission of trying to support individuals who are in need of behavioral health services and getting them out of the justice system, wherever that might be along the line. And so I wanted to take the time today to give you all the why behind why this is such a huge topic. It's a huge topic in Arizona, the entire United States, and understand the complexities in it and all the different partners that have to speak different languages, not tech languages, just different languages themselves. And I have some screenshots to show you kind of what our database looks like now, and get some ideas from you about as we move forward with trying to advance our mission around the state and offer something that could be a model even nationally as well. And I'm so glad so many Arizona people are here. It kind of helps me with my nerves and speaking to folks around the country. And so I'm hoping that you guys could understand where the boots on the ground folks come from, the ones who use the tech stuff that you guys can see your vision of something that might work really well. See it a little bit through our eyes, and it's like I said, it's great. I know that the Department of Corrections reentry is here, and that's huge, and some health plans, and then I do have, if we have time, I can touch a little bit on this other project that we're working on with the coalition under a different umbrella as well, Trauma Lens Care, which is another app, and that's the one of working with youth and trying to get them connected to treatment as well.
Cool.
Does that sound good?
Let's do it.
Okay.
Sounds great.
All right. So we'll go through some of the whys kind of quickly, but go ahead. Yeah.
Yeah. So just to, just to reiterate, if folks, they can chime in whenever they got a thought, is what I'm hearing.
Please
So,
do.
Okay, great.
Please do. All right. So folks with social determinants of health needs and behavioral health needs can come in and out of the criminal justice system just because of the fact that your social, economic, and environmental determinants of health affect your behaviors. The justice system affects your behaviors. That affects your physical and mental health behaviors. And so sometimes it can be kind of a cycle. And then other things that add to it, if you want to flip, there's homelessness. Folks who do not have safe housing or experiencing homelessness. There's a lot of ordinances and crimes connected to not having safe housing, such as asking for money or not sleeping in a proper place, trespassing, as well as mental health affects housing. Substance use then can affect housing. Sometimes there's an intersectionality going on, and it's not just one issue. Also, employment can affect your behavioral health. When there's times of less employment, then times of substance use can go up. There's always been, those memes and the jokes about the amount of drinking that occurred while everybody was home during COVID. So you can imagine that even in times of, hardship and recession, sometimes that leads to increased substance use. So that's another one. We have adverse childhood experiences, which is really huge in our world and understanding those. This is a research-based, evidence-based study, which we know that these 10 experiences, if a child experiences these during their childhood before 18, then throughout their life, you have a higher chance of experiencing adverse outcomes, including mental health, disease, and even early death.
So let me ask you a question here. There's a lot of work going on with ACEs around the country. Are you actually capturing ACEs scores now? Are they required by the pediatricians and assessments and schools, or is it just within the criminal justice system, or how are they being captured?
So in different areas, and it depends on, there's nothing required to capture ACEs. I believe that it's more beneficial to ask the ACEs questionnaire when a person is ready to then discuss something about it. So that could be with your doctor. It could be with your behavioral health partner. It could be the ACEs actually came from a weight loss doctor in the Midwest under Kaiser Permanente, and he had a clientele of upper middle class folks coming in, and they would work really hard and do a lot for weight loss, surgery, diets, all these plans, and then kept noticing that his clientele, even after they lost their weight, they started gaining it back again, and started talking with them and started realizing that the folks that were having a really hard time with obesity were having some of these similar experiences from their background. And that's actually where the ACEs came from. So it's used in different places, but we do collect this information for people who want to give it when they do get booked into jail.
Yeah, because we were involved with some work in California. They're just trying to mandate requirement, sort of required assessments now across the state. So capturing it and being able to use it as I'm not sure if that was one of the requirements that you had, you were thinking about as you're thinking about systems and databases and stuff.
Well, and what's huge about the ACEs is that these are some a little old studies, but we know that children, the more ACEs that they experience, the higher rate and possibility that they have of being involved in the justice system as a juvenile and then later on in life. Trauma carries a lot of weight with us. We know that, and I've heard it's even over 90% of the women who are incarcerated, they have a huge history of trauma in their background. And sometimes this can just cause this revolving door. And of course, it definitely affects your mental health and your behavioral health, substance use, which then can affect criminal justice. So everything that we're looking at in jail reentry coordination and actually deflection and diversion and not getting into the justice system at all, it's really important to remember where trauma may lie in there, whether you ask these questions or not, to understand that people come with a history of trauma. And so sometimes it's not just get your act together. There's another, part of baggage that goes along with it.
Yeah.
You can,
so Robin put another comment in the comment section about it not being required by Medicaid. So
yeah, to the best of my knowledge, it's not a required standard, but many of the Medicaid providers are collecting those scores.
And as an adult, then sometimes it's we use it also as a tool of having that conversation as well, of looking at where you can go from there. If you want to hit the next one. Another reason to think a lot about the intersection between behavioral health and the justice system is that, in all honesty, in a mental health crisis, people are more likely to encounter the police. And that could be because we are so used to calling 911. If my child or adult child, is in a crisis, is acute, maybe not taking the medication, something's going on, I want to get them help, I'm going to call 911. That's who we usually call, right? For an ambulance, for the fire truck, for police. And once law enforcement arrives at the scene, then that can start to lead down a path of not necessarily getting the person to behavioral health, and instead getting the person into jail. And in all honesty, if it is quicker for law enforcement to think that a safe place for this person to be can be in jail, and there's some charges that I could put there, then we were noticing that that was the path where the person who really needed behavioral health services would go. Once a person does come into jail and they have untreated behavioral health, they are more likely to stay in jail a heck of a lot longer than the general population for myriad of reasons. And they are at huge risk of victimization, especially when they're in jail or actually out in the community as well. Go ahead.
Yeah.
So then there's when people are coming out of jail. Oh, go ahead, Mr. Bishop.
Yeah, so I was just trying to imagine a world where, things might work better in the case that someone was arrested. Like, have you ever seen, work where whatever, let's say a crime has been committed, but whatever work, instead of the defense attorney would kind of, if the defense attorney knew that this was somehow related to some related trauma, right? Like that could be part of the defense. And then instead of that person going to jail, they'd be getting these alternative treatments. Is that kind of part of ATI?
That's where I'm leading up to, exactly.
Is that
Yep.
emerging? Is that?
Nope, that's what we're doing here. And that's where, yep, I'm leading up
Okay,
to.
I'm sorry.
Yeah.
I didn't mean to go
No,
ahead of you,
you're
but-
absolutely, it takes a lot to imagine, but, and I'm giving you the why behind, also why we're just now, some areas are kind of just now getting there. Like it's kind of hard, right? Like there's a lot of different languages between behavioral health and the criminal justice system. And yeah, so that's where we're leading up to. So, and some of the folks who are coming out of jail, here's some reasons for difficulties in getting back on their feet. The longer that you are incarcerated, the more chance that you don't have housing, that you've lost your employment, that your partner has said no more, that then it starts to tumble again. There's a difference between jail and prison. In jail, you could be here 2 hours, 2 days, 2 weeks, 2 months. You might think that you're getting out next week and you don't. You might think that you're not going to get out and you do. Like it could be really, really quick. With our DOC counterparts and the folks in prison, they have a set release date. And if they know that they're going to get out early, perhaps because of parole or something, there's still a set enough time ahead to do some of this planning. But in the county jail system, the planning needs to start immediately. So next one, there's lots of folks who are involved. And as Matt was talking about, if the defense attorney knew that there was some other options available, so what could that look like? But we have, child safety, probation, parole, developmental disabilities, housing, employment, our mobile crisis systems, education, and literally all these folks speak a different language. Even the entities that are in the criminal justice system, you've got the court and you've got probation, you've got patrol and law enforcement, the judges, the detention officers, they all speak kind of different languages. And so trying to work to get everybody together on this path of how do we identify people at the earliest signs that we can, wherever they land in the justice system, what can we do to deflect them out? How do we even stop them from getting in to begin with? Can cause it's a big one to take on. It's a big subject to take on. And it needs a lot of support. So Yavapai County years ago started looking at these two resources for a lot of their supports, for kind of toolkits. The Stepping Up Initiative is a partnership with the with NACO, the county associations, and the American Psychiatric Association. There's a few entities that are involved with the Stepping Up Initiative. And back in about 2015, 2016, they started putting together this toolkit and asking counties to make a commitment to reducing the number of people with a mental illness in jail. And then our National Association of Counties created this data-driven justice playbook, again, with the same idea of how do we work to support people with behavioral health needs who come into contact with the justice system. So if you see in these things, there's a lot when it comes to data and analysis. And what's really great is about these toolkits is to try to take out some of the historical shame and blame that occurs. So I've been working in the world of trying to help build processes between behavioral health and criminal justice for years. And what is so easy, or a great example of where this friction comes from, can be someone on the jail side saying, hey, mental health facility, if only you did your job, then these people wouldn't be in our jail. Or the mental health community saying, hey, law enforcement, if only you understood that this person was in a crisis, then you wouldn't be arresting my client, right? So it kind of goes back and forth. But what's fantastic is talking about an assessment, data, and then using that to prioritize funding and having a database and cross-system organization. So Yavapai County put together the Yavapai Justice and Mental Health Coalition, and that's with, and this is both adults and juvenile, and we have our county attorneys, elected officials, city attorneys, defense, and our superintendent's office, our teachers, education, health department, behavioral health partners, housing, emergency housing, and we have put together some goals and some work groups on how to look at the entire spectrum of where somebody can come into contact with the justice system and how to divert and deflect them out. And so the tool that we use for our assessment is the sequential intercept model. And this was created by the Gain Center and SAMHSA like over 20 years ago, but finally it's getting some momentum in the last 5 years. We've been lucky here in Arizona. Don, who's on the line, he has been doing a lot of work in supporting the AOC, or Office of the Courts, or Supreme Court, to kind of have our presiding judges try to help push this out amongst all of our counties. But what it is, it's obviously very linear when this population is not necessarily linear, but there's 6 places identified where somebody with behavioral health symptoms and unmet behavioral health needs can come into contact with the justice system, and where we can identify that what it is that they have behavioral health needs and how to deflect or divert them out. And Robin, I see your hand up.
Thank you. I know you mentioned a minute ago that y'all collectively are working on this effort with both the adult population and youth. Is the sequential intercept model also established to work with kids, or is this primarily designed as an adult model?
So this one seems kind of like an adult model. We have, and I'm going to show you a little what our mapping looks like for Yavapai. We've used it for both with the kids as well, but not necessarily as intensely. And I heard that there's like another one that helps a lot with the process with the kid model out there.
Okay, thank you.
Yeah. So intercept 0 is no, if you want to go back really quick, no law enforcement involvement at all. What's already established in your community. Intercept 1 is law enforcement comes along. And so what do they have available to them to identify folks who have a behavioral health crisis, and what can they do to deflect them? 2 is you're getting into the jail. How do we identify that right away and get to the information to initial appearance? Intercept 3 can be specialty courts, sometimes with the courts. And then while folks are just in jail, what are we doing to support them? 4 is reentry planning, and 5 is working with our correction or community corrections partners, probation and parole. Okay, so now you can skip to the next. So I have a clearer picture on the other one. We've broken up each of those intercepts. And then if you want to go to the next one, I'm going to show that I've used it as, this is just a little shot, but we have used it here in Yavapai as our community assessment plan of what do we have down to as detailed as we can get. What are gaps and challenges? And of course, how do we get the stuff from the right side over to the left? And over the last 4.5 years, we've done a really great job in addressing a lot of our gaps and challenges. And actually, right now, some of our biggest pieces are bigger systemic barriers, such as accessible housing, which is everywhere. So go ahead. We received in Yavapai County a Bureau of Justice grant back in 2015 to start this post-arrest diversion program. And in the BJA grants, they have a law enforcement mental health collaboration grants that are available, and they require third-party evaluation. So we partnered with the Wellington group and to do the third-party evaluation, and she said, yes, this is great. I will create this database to collect the post-arrest diversion piece. And so then our captain, who is now the sheriff, kept saying, but wait, I have some more ideas. Wait, I have some more ideas. Wait, I have some more ideas. So this database continued to grow, and it is on FileMaker, which I don't know if everybody tells me that that's an old antiquated system, but we do not. But this is what we have, and this is what we're working with. And the majority of these tabs that we use is the pre-arrest diversion, the reach out, and the follow-up, release, and the export data. So I was going to go through a few of these steps. How old is FileMaker? I have no idea how old.
I know, I was asking the nerds out there.
It's a couple steps above clay tablets. Thank you. And
it's about 20 years old at least, but there's still stuff out there.
It was cutting edge though, wasn't it?
It was actually very easy to build applications, and the first juvenile justice application I built was actually built in FileMaker. So and that was converted around 2001. So, and it had been around for about 10 years prior to that.
Didn't they have carburetors too?
Yeah, yep.
So for the Intercept one with law enforcement and supporting law enforcement, we've looked at different elements of a strong pre-arrest diversion and deflection system. And if a lot of it starts with giving the first responders tools to be able to identify when people are in a behavioral health crisis, and then tools to hand them off to somebody and our partners, and really kind of going in depth. And so 2 of those programs that we rely heavily on is mental health first aid. They have one for first responders. Mental health first aid is great actually for every single community member, person, everybody on this line. It's kind of like taking a CPR first aid class to identify what's going on and what do you need to get to the person to the next step, wherever level of care that might be. And then the other one is crisis intervention team training. That's a 40-hour training that law enforcement, first responders, our dispatcher, detention folks, probation are all welcome to come to. And that kind of really dives more into what is happening with the brain, what happens with addiction, and then what happens with Alzheimer's and PTSD. And then we have lots of our community members come and help facilitate different portions of that 40-hour trainings. And so that provides also this ability for these first responders to look the behavioral health folks in the eye and everybody say, yes, we can do this. We can absolutely work together. So the piece on our database that we have incorporated is to be able to record when somebody is deflected. In Yavapai County, in our large county with small amount of people, we have 12 law enforcement agencies and 5 dispatch centers. and they don't have ways of talking to each other. And this database is actually the only common database that all of these law enforcement agencies have to talk with each other. So what we have done is ask all 5 of those dispatch entities that if their first responders, if their law enforcement comes across somebody for whatever reason, and they do not take the person to jail, but instead they do something related to behavioral health, whether that's handing the person a brochure or a crisis number card, or calling out mobile crisis teams, taking them to our crisis stabilization unit, having to take them into a civil commitment process, anything else, if we can record it in the database. And then this way, if another law enforcement agency finds this individual, Jennifer, and says, gosh, I really feel like something's going on that's different with this person, they can ask and say, hey, does Jennifer have, is there anything for this person, Jennifer, in the database? They see that there was a mobile crisis deflection. This isn't HIPAA information. They're just saying there was a mobile crisis deflection that happened. And then they took them over to VVMC. Well, then the other agency, hopefully then they can have an idea of like, well, maybe we should call mobile crisis back. Maybe there's something else that's going on. They can also call up and, you know, ask if there's a history of folks in this database, just to kind of have an idea of what's happening. Then on the coalition end, I'm able to see, was this Jennifer? Have there been a lot of contacts for Jennifer? Because one thing I will tell you that is frustrating to law enforcement is when they feel like they're seeing the same familiar face over and over again, back to this whole like, hey, you're not taking care of this person. But then we can pull in the parties that might be able to support Jennifer and say something's going on, and try to take it from there in, of course, a way that protects PHI and is HIPAA compliant, but what resources are available, just to give a heads up to the mobile crisis and saying, hey, we have lots of Jennifer contacts, what can we do? So the next piece.
So how do people access? I mean, who is this, like password protected or role based, or is it just whoever can get on a PC or phone?
No. So it is, you are given permissions to certain parts of the database. So dispatch only has this section available to them. And then law enforcement would just call and ask if that person was in there, but it's all then under their policy in house of this is not shareable information. This is crisis information to be shared, the same as not sharing criminal history to your partner when you get home that day of yeah. But yeah, so this is definitely permission driven. And then for the next part is our jail reentry planning, and we call it reach out because we know that again, we need somebody, coordinators within the jail to work with the folks who are being booked in to get them connected to the services on the outside. And what that would mean is there's some steps on the next slide of just, again, it looks very linear, but of course it can bounce all over the place. So everybody who gets booked into Yavapai jail has the option to meet with a release coordinator or an inmate services coordinator. And we do a screening. The screening includes 10 questions related to mental health, 10 questions related to substance use. Those were off of an evidence-based screening, but we shortened them. There used to be like 17 questions each, but now they're 10. Robin, go ahead.
No, finish your slide. I'll talk when you're done. Thank you.
Okay. They have the ACEs questions, we have social determinants of health questions. Do you have housing? Do you have transportation? Our jail is currently, it's really, really rural, that you walk out and we have a wildlife, lions and tigers. You can come feed the tigers if you want, like, right, we kind of share the parking lot with them. And then you have to go 3 miles to the interstate, or you go 15 miles to a town, and we don't have public transportation. So asking transportation is really, really important. We ask employment, if they're a veteran, some other information that would be beneficial in trying to think about to make a release plan. The database scores these folks, and I have data to show you on what it looks like. And it'll show if you're moderate or high risk for something. If the screening's completed, the database generates a post-screening report. The post-screening report then is available for the initial appearance judge. So that initial appearance judge can be like, ha, Beya, what's happening? Oh, well, you were screened and it shows that, and it'll say if the defendant is released. So we're not making a recommendation at all. It's just if the defendant's released, the defendant has agreed to the following things. Go get check back in with Palara Health, and go to Angie's transitional housing, or go stay with my sister, and any other information that might be available. So they can utilize that. We worked with our presiding judge to create an additional orders of release. And so the judges can use that to help a person be released, that says, okay, Beya, we're going to let you go on your own recognizance, but you're going to follow what's written on the post-screening report. And there's a couple other areas in there that the judge can add some more stipulations to it. So if somebody is getting released immediately at initial appearance, we try to work with what they have suggested and said services that they would like to be involved in. And if they're not immediately released, then we work with them while they're staying incarcerated as well. And the information that we collect is based off of what they disclose. So we'll have people that we know who have a serious mental illness, who came in here higher than a kite, and who have been involved with all these other treatment plans. And if they say, oh no, everything's fine with me, I'm never depressed, I don't have any substance use, then that's what we record. But we still continue to work with them and try to make sure that they get connected upon their release. We work strongly with probation, to the point that we now have a probation officer, part of our reach out department. And we have quite the population of people who are on a probation enactment. It's kind of like a timeout. So, hey, you've not been following what you're supposed to be doing. It's looking like it's due to substance use because you have dirty UAs. So you're going to get 90 days back in jail on a timeout. However, you can get released early into treatment. And it takes a huge coordination to release people into treatment. So historically, probation officers would say, oh, well, look at that, Beya is safe, I'm going to go deal with the other 75 people that are on my caseload. So now we're able to say, oh no, wait, stop. And we'll look at the court orders. We'll start with adult recovery team meetings. We'll get packets completed, the packets over to our behavioral health partners. They'll do a secure visit and do a assessment plan and a treatment plan, and start releasing people early. So instead of 90 days, this person's now out at 45 days and into residential treatment, or people that need to go into inpatient treatment, whether they're on probation or not. We can work with the courts. There was the question, I think, that popped up that said, how does the court know if somebody has all this trauma and something else happening in their lives? We have inmate service coordinators, release coordinators. We have behavioral health professionals here on staff. And then we communicate with the attorneys and say, hey, this is what's going on with this person. We've had this behavioral health provider come in and do an assessment, and they're saying, yes, they meet this level of care. Would you amend their order and let them be released into all these wraparound services? Or sometimes we have people who are just temporarily released and they will have to come back, but at least they can go to an inpatient facility to become stabilized on medications and other mental health treatment, because jail is not mental health.
Yep, going the wrong way.
So I have
Is that the slide?
yeah, I was reading Shelley's question and I'll come back to that later. So I was going to show you guys just a quick screenshot. So these are 3 different screenshots. We go onto the database, we search somebody's name, if they've already been there. If not, we make a new record. It'll let us know if there was also a pre-arrest deflection. So then when Christy here pops up, she's been screened, but it's automatic pop-up so that I, as a coordinator, can look in there and see that what her screening results were. I can see if she's got a release of information put into the database. And then if I hit that go to client profile, that'll get you to your next screen. And then it starts showing, it's a long screen. So I have 3 quick, I believe like 3 of these screenshots for you, but just to give an idea of, here's the person's what they screened at for their risk. If they have our state Medicaid insurance, what their employment was, and then their booking information. If you go down to the next one, where they're supposed to go to court, if they had a post-arrest diversion referral, what their treatment coordination is. Those buttons on the side generate what they say. We could see past screenings and past case notes if a person was here before, what their release of information is, because that's really important, and I'll explain that with our other partners in a minute. So if you jump to the next one, I think it goes to our case notes. Oh, if we have what referrals that we've done, and there's some drop down buttons for different referral that were already populated in there. And so that stays with us. And this is if the person gets released, what was the status of their release? Did we connect them? Did we divert them? And I'll explain that in a minute. And then the case notes at the bottom, like they can just go on for a very long time, explaining what the coordinators have done to assist them. So the release of information, we have asked and right now it's just 3 main community behavioral health providers, because that's what's in the database and we can't change anything at this point. We have asked them to support us and to also get information about their clients from us. So they have certain permissions in which they go to post-release treatment. And when we have a release of information uploaded into the database, signed by the patient, the client, the member, the inmate, we click the button that says what behavioral health provider that release of information goes to. So then our behavioral health providers can get into the database, and all they see are individuals who have a release of information for them. And what we have asked them to do is to go in and do a 30 and 90-day post-release follow-up to let us know if the person stayed engaged in services, and what was their level of engagement when they were in services for various reasons. One of them is to let us know if are we actually even doing it? Like, we're saying we're connecting you to services, are we getting you to services? If the person comes back, we'll know a little bit of information. If they said that they went last time, but they really didn't go, like, how do we use motivational interviewing to help them to go again? Our behavioral health providers can have access to the screening results that they have and all the questions that they've screened, so that they can use that information with case management and supporting the person as well. And just a lot of like efficacy and data follow-up after that. So the next screen shows a couple of those questions and what it would look like to the inmate services coordinators when somebody comes back. Did the person enter treatment? And what's the status of entering treatment? And then if they do come back to jail, then we also put in why they came back to jail. Whether it's a new criminal charge, a warrant, or a probation or court hold, or the different reasons as well. So Robin, I was going to jump into some data, but did you want to ask your question?
Actually, I just wanted to make a comment about two things specific to Arizona, but relevant maybe to the group as you're working in other states. Medicaid waivers are really targeting two areas that I think speaks entirely to this population that Beya is discussing. Those waivers are now carrying a lot more supports around housing and expanding the array of what Medicaid can do to help people secure affordable housing. So I'll leave it at that. But if you're not familiar with what your Medicaid system in your state's able to do, those housing expansions, our state just applied for an expansion on what we can do and was granted that. The second area is that many of you know that people lose their eligibility for Medicaid once they go behind the fence. And it's probably more impactful to think about it from a Department of Corrections standpoint, but it occurs in jails as well. And again, our state in Arizona, as did other states, have put in for waiver exemptions to be able to actually go in behind the walls anywhere from 30 to 90 days pre-release to start engaging Medicaid eligible people to do exactly what Beya is describing in terms of coordinating these release programs. So it's exemplary of what they're doing in Yavapai County. It is now something that's happening more and more around the country, and California also just passed that. And I think theirs is a 90-day pre-release that you can now go in if you're Medicaid eligible. So I just wanted to share that.
Thank you, Robin. And that the Medicaid barrier is huge. And I will argue that actually in jails, it causes a lot of issues. All of our providers who are on board and helping us, and they're amazing and they do a great job. They are billing grants and they're billing community reinvestment funds. They cannot bill. It's a federal mandate. You cannot bill Medicaid while somebody is incarcerated. And then this Medicaid, some of the Medicaid waivers that Robin has brought up about saying, hey, we'll let you go in 90 days post-release. Well, that's great for a prison. But like I said, we don't know. 85% of the people in our jail are pretrial defendants. They haven't been sentenced yet. You don't know necessarily when they're going to get out, and we need to start coordinating right away. So to be able to lift that completely would actually be the most beneficial of all, because it's a discontinuation of care and we need those outside providers to be able to come back in. So the data that we're able to collect, well, first of all, I want to say that as you guys, as the computer programmers who are able to help us on our program levels build something out, I beg of you that you ensure that your customers get to test their product. And one of the hardest pieces about our Taj Mahal that's now on stilts is that we never got to test it. And what happened, like we would see this beautiful PowerPoints of saying like, hey, don't worry, your days of using an Excel spreadsheet are coming to an end. And this is what it's going to look like. You'll be able to come to this page and put stuff in. You'll come to this page and put stuff in. And the folks at the jail were just like, oh, this is going to be great. This is wonderful. So then they gave the product. And when the folks who actually do the work sat down, they said, oh, no, wait a second. We need this button to say this, or we need the option to capture this information and not that information. And the reply was, oh, no, you don't know what you need. We know what you need, and it's already built and it's done. So that's when I said there's a lot of pieces in this database. It's done a great job. It's collected a lot of data, and it's time to move on. And as I see different ideas from Sean Gunderson's partners and his friends, I'm just like blown away over how much more we can do in case management and tracking and talking to our friends and our partners and identifying like where the holes are. And I mean, that whole pre-arrest deflection piece and the dispatchers needing to put the information in, it doesn't talk to their system. None of this talks to our jail management system. Exactly, Michelle, exactly. Trying to get your car organized. But it's cumbersome. However, I am able to pull lots of great data out of this. When in 2018, the sheriff's office went to the state legislature and said, you know, we don't want you, the state is responsible for financially paying for the prisons, not financially responsible for paying anything for the county jails. But the argument was, let's stop sending people to prison. Let's try to help them when they come to the jail. And so Yavapai received a $1.5 million appropriation to start this pilot program. And the idea behind it was that we would have also a third-party evaluator with us, and we can show recidivism tracking. And so we have partnered with Northern Arizona's Center for Health Equity Research, and they export our data and they do all the amazing stuff. They can tell me, you know, if you have this kind of characteristic and you're using substance use is moderate and you're homeless and you don't have a PCP doctor, your chances of recidivating are at whatever level. Like we get so much information from it. Yeah, Robert?
Sorry, I was muted. I was just going to ask, first I wanted to say, I hope it wasn't too hard on your FileMaker Pro system. It could be up to 40 years old, depending on how what version you have, but they have done a pretty good job of keeping it current. It's just kind of an odd software product compared to other things that are out there. But I was just, with this particular slide, how are you measuring recidivism, or defining recidivism, I should say?
Thank you. So
because nobody does it correctly.
Our coalition decided way at the beginning that we were going to define recidivism by new criminal charges. So I am
For a
able to
particular
measure
period of time.
new criminal charges, yes. So what we have decided to do is look at 2 years, a 2-year cohort of releases, and then add an extra 6 months on the end so that the person most recently got released has some time to get into trouble. So this data right here, it's the 2 years of releases between April 2020 and March 2022. And then the data was pulled in October 2022. So those people that got out in March still had 6 months to get into trouble. And that's what we...
I was just going to say, I would suggest that you try to go for 5 years, because 2 years is what most people do. And
well, we
having
just started this in 2018, so there had to be a chunk there somewhere.
Yeah, the problem that you run into, because I can only speak from juvenile data, but that was kind of the standard. You know, look 2 years out, see how they're doing. But I always looked a little beyond that, and typically saw a hockey stick at about 27 months. So you will see this curve that goes up dramatically, starting, you know, middle of year 3 into year 5 in terms of incarceration. You also need to account for death in there as well. That will skew your numbers. A lot of times they don't take that into account, but especially for younger offenders or juvenile population, the death rate tends to be rather high compared to the average population. So your recidivism numbers will get out of skew if you don't count that.
Thank you. Yeah, so we started, the data that we have starts from March of 2018. And we do have looking at every 6-month gaps up to those 24 months. But as we do hit like a 5-year mark, that's coming up, you know, that will be interesting to be able to, let's look at what happens on even a longer longitudinal area. And another reason of trying to cap it a little bit smaller was because we're trying to change policy on a statewide level. And our folks down on the policy side, they're not necessarily going to be here for 5 years to see then what happens on the next 5 years. There is nothing, and I don't know, I think, Dawn, we even asked you, but we can't find anything statewide that says the county jails recidivism rate was this X before we started, and having a defined amount of time and having it defined as new charges. So that's been kind of rough in saying, hey, we're going to track recidivism when there was not a baseline out there to track it from. But as you'll see, about 50% of more than 50% of the folks in this cohort disclosed medium to high mental health risk, and almost 50% disclosed medium to high substance use risk. And then the next slide shows other risk factors that we have. And one of them that's huge is that homeless risk factor. So a quarter of our jail don't have safe housing. And I will say that the characteristic of not having safe housing and disclosing homelessness, that population definitely recidivates at the highest rate out there. And of course, then the more of these risk factors together also show the higher rate of recidivism. Another piece of data that I pulled for you all on the next one is looking at what we connected folks to. So it's housing, and then the middle one that you don't see is transportation and treatment. Out of these 10,000 individuals that we contacted, and a little more than close to, like, obviously 5,000 answered the questions. Over 4,000 were referred to treatment, 2,000 connected, and that diverted piece is really, really huge, because those are the people that we can honestly say that they left jail early because of the coordination. So whether that was through that probation, early release to treatment, or it's because we worked with the court saying this person needs inpatient and to release them there. And then our recidivism rates are actually on the next slide. And so our general population all the way around, for everybody, regardless if they answered the questions or what the risk factors are for that time period, the overall recidivism rate was 17.3% for people with new charges. Our previous cohort that we had done with the same time frame, it was 18.5%. I got really excited that we were actually, like, finally showing that we're reducing recidivism. And then it occurred to me that part of this time was when we weren't taking misdemeanor arrests because of COVID. So that might skew it a little bit, but I'm still excited that it's at 17.3%. But then also what's huge to me is that those folks that we actually got out of jail early, like, we changed their order, we amended their court order so that they can be released, they have the lowest recidivism rate of 15.5%.
You know, I want to ask you in the like 5 or so minutes left we've got, if there's, what's your question? You know, what can people help think about? Now, obviously not only in the next 5 minutes, but are you coming to this with a particular question, or just you laying it out to say, here's the complexity, how do we move from where we are to a new generation?
It's the complexity, and it's to understand that as the folks who actually work, that you are the ones building this interoperability world of all these different entities that find it difficult to speak with each other without using a computer screen, like understanding how complex it is just to make it to this mission. And it's showing an example of what communities are doing in order to address a health and community issue and a justice reform issue. Because if you reduce recidivism rates, that means that crime isn't happening, and that's definitely a desire, right? And connecting people to services instead of incarceration is justice reform. And so as we're moving through all of these areas in our country and looking at what can be done on a social and criminal justice level, these are just all the different pieces that need to go in there. And as we're looking forward, and I'll let you guys know when the RFP comes out for that new database to be built, if you want me to, I can send it to Dan and you can send it out to your teams if anybody's interested. These are the areas that we're looking at what to incorporate.
I'm curious, did you put out an RFI or did you do any community solicitation for ideas before you put out your RFP?
So it's the state that did it. It wasn't actually us. There's the Criminal Justice Commission, but they did put out an RFI. Yes.
Okay, so it was built from that a little bit then already. Well, that's interesting.
And it's built also, it's going to be a little bit built around that nerdery report as well.
Well, it seems to me that, so many of the challenges of so many different programs having so much different information, so many different places, it's the same problem in the non-criminal side, right? Just with people who are just, well, whether or not they're able to hold on to their children, or just simply, health, homelessness, behavioral health, not yet connected to the criminal justice system. It's incredibly complex as well. It just seems like, to me, how do we bring criminal justice into that larger population health management solution, the overarching whole person care kind of thing? We're focused a lot on that now in California, is trying to build that platform statewide, so that you don't have all these different sort of galaxies within a state trying to both build, maintain, and then interoperate. I don't know, do you see Arizona moving in that direction, or do you still see it sort of every county for themselves?
So I think Arizona is definitely moving. I almost lost you there. The push, part of the appropriation that's going through the legislature right now, we've already been able to give startup funding for 2 other counties through that appropriation, and right now it's going to be up to a total of 5 counties, and we're looking at trying to make policy change so that it's an ongoing budget line item. The idea that John had of spreading this database so that it's available for all counties then provides this model moving forward. Yavapai County is being seen around the state as a model for jail reentry coordination, and then the pieces with pre-arrest deflection for law enforcement, I mean, that is definitely on the national stage. That CIT came from Memphis years ago, and that's a huge one. There's another one out of having law enforcement work with the communities whose children have autism or developmental disabilities so that they can get used to each other and build relationships as well. So it definitely took off a few years ago. Things might be shifting a little bit, but that's how politics are.
Yeah. So I think Rob has his hand up, so we'll take the last question from Rob and then close up. Yeah,
so are you able to overlay juvenile data on this as well? Or does that get segregated out?
No, juvenile data has its own set of protections with it.
Well, I understand that. It's just, you'll see a different picture if you're able to look at them together.
Oh yeah, no, definitely. I mean, we work with our juvenile partners for sure, but they would. So are you asking, like, could juvenile take this database and put their information in it as well?
Yeah, essentially. I mean, I don't know how you would handle the protection aspect of it, but it would change what your recidivism profile looks like, especially depending on what, I don't know what Arizona's laws are related to adult charges being assessed against juveniles. So you can end up with some weird situations there.
Great. Well, Beya, I want to thank you for sharing with us what you got going here. It's amazing work, and it's just horrendously complicated, like everything else. And so, you know, we'll share this recording. We'll put it on the NIC site. PowerPoint, I think you can share. We'll be able to share, and contact information we've got. So if people want to reach you, is that good? And if you've got questions that you want to share back with us, we'll be delighted to entertain them.
Please. Thank you.
You bet. So in about 3 weeks, I'll send out a notification for a review of sort of the state of the agenda for the HIMSS conference, and look forward to folks who want to join that sort of think tank to join us then. And be well. Thanks a lot. Talk to you all in a couple weeks.